I apologize for starting to return to record late. Thank you. Please go on.
Sure. So our peers in primary care and our patient-aligned care teams, they see a wide range of patients. Some of them are new to the VA and transferring care. Some of them, and this is by a colleague, a peer specialist colleague, he said some of the patients he sees are just overwhelmed. And sometimes the primary care team says, oh, that veteran would be great to work with our peer specialist. Many of the patients he sees are transitioning out of the military. Some are patients who are declining mental health, but might benefit from additional context. And some of the patients that the peer in primary care sees is they need more support than the provider can give, than the nurse or the doctor can give. And they're doing a lot of whole health coaching with the veterans. And he's being assigned veterans who want to work on behavioral change. Next slide, please. And this slide is from the supervisor of this peer specialist. And so she hadn't worked with a peer specialist before this, since this peer is new to primary care, relatively new to primary care. And she really feels that the peer provides an important perspective in caring for patients that she hadn't seen before. There are additional approaches now that they can offer. She says he's the best at connecting to patients who are having more difficulty connecting to services. But as I said before, this peer survey helps her be more mindful about stigma and her words and what might be going on the team. And also the peer connects to other peers throughout the system. So there might be a housing need, there might be, other types of service needs that this peer can connect veterans to. And as Kevin said before, what the peer brings to the team is understanding the many VA programs available to veterans. So we're really excited about the expansion to primary care and very excited about the expansion to pain management, which is a further extension of primary care. So thank you.
Thank you, Anne. Okay, so now I'm going to talk a little bit more specifically about chronic pain and pain management teams in the VA and how we're getting peers involved there. So I'm going to do just a quick background for anyone who isn't particularly familiar with chronic pain. Pain, as defined by the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And that's the definition they give, and then they give 6 key points about pain. And one of them that I think is important to highlight is that pain is a personal experience that's influenced by biological, psychological, and social factors. And because of that, chronic pain is complex, and because it's complex, it can be difficult to treat. Chronic pain is often also very common. So somewhere between 15 and 43% of US adults have chronic pain, and 8 to 10% of US adults have high impact chronic pain. So pain that is disabling or limit work and family activity. And we know that pain is more common in veterans. And so it's very common among people who use the VHA for healthcare. It's also the second most common reason for outpatient visits. So that's where this expansion to PACT became really relevant to me, is that, pain is one of the most common presenting problems in primary care. We're now putting peers into PACT, into primary care teams. And as a result, they're probably going to see a lot of patients with pain and be tasked with working with patients with pain. And how can we do that better? At the same time, we know that medical school does not a great job, although it's slowly getting better, at helping people learn about pain and how to manage pain. And so how do we manage, what is the best science on how we help people with chronic pain? We usually think about pain through a biopsychosocial model, and emphasize that each of these 3 domains, biological, psychological, and social factors, all impact the pain experience. And so when we treat chronic pain, we want to optimize function as the guiding principle, and we want to be taking a whole person approach. So for example, substance use can impair function and can impact pain. If you're experiencing depression or anxiety, that can have a negative influence on pain. Pain can also worsen mental health symptoms. So we really need to think about the connectedness of all of these factors, and we can't provide effective pain care if we're just ignoring certain parts of this. What is good pain treatment? In the clinic I work in, we say we want to take a collaborative approach so we can support you to feel better overall if you're willing to work with us. We want the patient with chronic pain that we're seeing to be at the center of our team, like the most important and valued member of our team. And so to do that, we take a biopsychosocial patient-centered pain assessment where we're really focusing on functional goals. What does the patient wish that they could do that they're not currently doing? We want to emphasize a multimodal treatment plan. So we never think that just one thing is going to help pain. It's usually a bunch of different ingredients that make up a good pain management plan. And then because of the population we serve in our clinic, which is patients who are having problems related to opioid safety, providing better education about the role of opioids in managing pain. And for a lot of our patients, some education and some exploration around the idea that opioids might actually be hindering them in helping them manage pain rather than providing a good treatment option for them. So as I mentioned, good treatment for chronic pain involves a multimodal treatment plan. And this graph shows sort of a visual for how we think evidence pain care should work. This is supported by the Institute of Medicine and the Department of Health and Human Services. And so we think that, good chronic pain treatment usually involves some sort of pharmacological management, but also physical activation, behavioral therapies, and then in the background, supporting patient self-efficacy and patient self-management, addressing comorbidities, and addressing and promoting healthy behaviors. And in an ideal world, this all happens in an integrated health system that's working together as a team, which is one of the things I like about working for the VA, is that we get to do this sort of as a team. And I've said multimodal treatment plan a couple of times. What do I mean? So these are some of the evidence-based non-pharmacological treatments for chronic pain broken down by category modality. All of these have multiple randomized controlled trials showing that they're helpful for some patients with chronic pain. And the underlying ones have lots of evidence and, importantly, durable effect. So how does the VA think about treating chronic pain? This is the VA's stepped care model of pain management, which came out about 10 years ago now. And you see at the foundation, there's sort of self-directed self-care things that patients can do fairly separately from the healthcare system to manage on their own. Step one is things that we think can happen mostly within primary care. Step two is specialty care, which is the type of clinic I work in and I'm talking about today. And then at step three, we have these advanced tertiary pain centers, which are often involved like intensive inpatient programs that people go to. You can also see, there's some blurry lines here. Some interventions fall under more than one step, so it's not exactly a linear progress. But like I said, in step two, one of the things is an interdisciplinary pain management team. And in 2016, there was legislation, the CARA Act came out, and this was legislation mostly related to addiction, but one important piece of the legislation was that it mandated the development of pain management.
I'm in now, it seems like.
At all VA medical centers. And that legislation said that these teams, to be for the mandate, needed to have a medical provider with pain expertise, someone with addiction medicine expertise, including the ability to assess for opioid use disorder when relevant, someone with behavioral medicine expertise, and the ability to provide an evidence-based psychotherapy for chronic pain, such as cognitive behavioral therapy, and someone from rehabilitation medicine, such as a physical therapist. So you see right now, there's not a peer on this list. That's sort of the overarching goal of what I would love to see happen. So this law has been out since 2016, and lots of VAs had interdisciplinary pain teams that looked a lot like that well before 2016. But these pain management teams really vary in the structure, in the focus, in disciplines represented. Some of these teams primarily do consults, right? So they meet a patient, do an assessment, give some recommendations, and that's sort of the end of their work. Whereas other of these teams do more longitudinal follow-up. So I'm going to talk a little bit about the clinic that we have at VA Connecticut, which is called the Opioid Reassessment Clinic, or the ORC. And we, I think, are best thought of as step 2 in that stepped care model, and as one of these CARA mandated PMTs. So the VA Connecticut Opioid Reassessment Clinic, our mission statement is to provide consultation and limited follow-up to assist primary care in the assessment, management, and treatment planning for patients with chronic pain who are on opioids who have some indications for reassessment of their opioid regimen. So problems related to safety or efficacy or potential misuse of their opioids. And our clinic staff include a general internist with training in pain and addiction, an addiction psychiatrist, an advanced practice registered nurse, a clinical pharmacy specialist, I as a clinical health psychologist, and Dan Rogers, who's a fellow with me this year, and a nurse care manager, and then Kevin Fisher, who we've recently added as a peer. So I wanted to give you just a little bit of a sense of how the clinic is working and how we've started to integrate the peer specialist into our clinic. So this is the flow of what happens. People's primary care providers discuss the referral to a patient and put in our system a consult. That consult's reviewed by our physician, and the nurse care manager calls the veteran to tell them about the clinic, what's going on, why they were referred to the clinic, and then they get scheduled for an intake. Before they come, we do a structured chart review to try to understand as much as we can about what's been going on with patients' pain and relevant comorbidities. And we present, the person who does that chart review presents that to our team before we meet with the patient for the first time. Then we have an intake visit where we have clinical health psychologists and another medical provider from the team who meet with the patient and ask questions. And sometimes we've been having the peer join, and then sometimes the peer, because they're doing follow-up, we only have one peer specialist, has not been able to join. And so we're sort of still playing around with the value in the peer being in that whole intake, because those appointments are pretty long. So it's a big ask of the peer, who would mostly be in a listening role during that appointment, but also is nice to have them meet in here. So maybe Kevin later, when Dan talks with Kevin, can speak on that. Then we do a team discussion and then some treatment planning. We try to come up some options of treatment options for the patient, and then the team goes back and presents that team. And then we do follow-up visits. We offer treatment with health psychology. We do regular follow-up appointments as we're making changes to meds. We refer them to other treatments like physical therapy, aquatherapy, acupuncture, those kinds of things. And now in just the past 6 or 8 months or so, we've been able to offer them the chance to work with a peer specialist. We've published a little bit about what our clinic is like. And so just to give people a better sense of who we see in our clinic, most of the patients that come to our clinic have a history of substance use disorder, mental health disorders. Many of them have been, according to their prescribers, their primary care doctors, having some problems with misusing opioids, so taking them not as prescribed in some way, or there's a safety concern, or maybe the opioids are not working very well. And then in a second study we did, some of the patients who came through our clinic were offered, who were deemed appropriate for a change, were offered the idea of a slow taper versus transitioning to buprenorphine. And we've been having a lot of success with trialing buprenorphine as a different treatment option for patients. And we got about half of patients during the second study period to engage in some sort of non-medication treatment, such as health psychology. And patients typically stay in our clinic for 6 to 12 months, depending on what's going on with the patient. So in that study, we found about 70% of the patients that we saw went back to their primary care and had their primary care take back over management within 1 year. So in my research so far, I have found that providers really describe that communicating about chronic pain is one of their biggest challenges. And there are a lot of barriers to getting patients to engage in evidence-based multimodal pain treatment on providers' parts and patients' parts. So both providers and patients say they have some skepticism about efficacy, or they don't know a lot. Patients report they don't trust that these kinds of things will work. And so I had done a group-based shared medical appointment to try to do a better job of giving people information about evidence-based pain treatments. And what I found when I did that group, I then interviewed the veterans who participated afterwards, and the things that they liked the most, and that was the most powerful, was hearing from other veterans. So I tell this story. I had one group where none of the veterans who came to that group had ever done our yoga program at VA Connecticut. We had a yoga specifically for chronic pain. And I was the one who brought up and said, did you guys know that there was yoga here? And they're like, no. Does anyone want to, I tell them a little bit about it. Does anyone want to try yoga? No, no one wants to try yoga. A couple weeks later, I have another one of these groups, a different group of veterans. And one of them says, did you guys know that there's yoga for pain here? I did it. It was great. I think every single other person in that group asked for a consult to yoga, and many of them went and enjoyed it. So to me, that just spoke to the power of a person with lived experience being the one saying, these treatments work, give them a try. My expertise as a pain psychologist, I can have worked in this clinic and worked with patients for pain for 10 years, but someone who says, I did the yoga, I liked it, is a much more powerful intervention than me telling them what I know about why I think yoga works. And so as Anne mentioned earlier, the role of peers in VA has recently been expanded to include peers in PACT. And people in VA are starting to do more and more research on, can peers be a helpful component of chronic pain treatment? And actually, there was one VA study recently that tested reciprocal peer support. So the peer was a volunteer who maybe got like a one-time 8-hour training. And then they sort of helped the other veteran who was enrolled in the research study. And interestingly, that study did not find a positive impact on the participants. The patients in that study were randomized to either get the peer or kind of get usual care. And the patients who got the peer support didn't get any additional benefit on the pain outcomes and quality of life and mood that they measured. And to me, I really wonder if that speaks to the idea that to help these patients, you need a peer specialist, somebody with a little bit more than a volunteer and a little bit of training, but I don't know, the jury is still out on that, I think. We also have an ongoing study that Kevin is involved in where peer support is one optional component of a multi-component intervention that's helping veterans who are voluntarily tapering their opioids to provide some support. And then there's another study going on across VA, 3 or 4 different VAs right now, that's evaluating health coaching, whole health coaching as a part of pain care. And although that study isn't about peer specialists or peer support, it just so happens that a lot of the health coaches in that study are peer specialists. So both of those studies are too early on to have any results or sort of know the effect, but I'm very curious and sort of waiting to see. But in some of my work, I have been trying to disseminate our clinic model to other VAs. And we work with a veteran engagement board. So it's a group of veterans from across the country. There's about 12 of them, and they all have lived experience with chronic pain or opioid use or opioid use disorder, because that study is a little bit more about opioid use disorder. And the veterans on that board are very adamant that peer support should be on these pain teams. We hired Kevin Fisher to work. He's been with us for almost a year now, and he began to work on our pain management team, the Opioid Reassessment Clinic, in the middle of 2021. He can share with you himself, but he has high impact chronic pain. And so Kevin, as a member of the team, attends interdisciplinary intake appointments as he's able. He also attends our team meetings, and he offers individual sessions to all the veterans who come to our clinic. And in those sessions, he focuses on helping them engage with the team, helping them think about pain self-management, and encouraging them to engage in evidence-based pain care. All right, and I'm gonna let Dan take over here and talk with Kevin a little bit more about what we've learned so far.
Yeah, thanks, Sarah. So we've got a couple additional projects in the pipeline investigating sort of the acceptability, feasibility, and outcomes of peer specialists on these pain management teams. Starting off with a couple pilot qualitative studies, the first of which that's going to be looking to interview peer specialists who've been incorporated into pain management teams across the country, looking at their perceptions of how well they've integrated into the team, their perceptions into their role in the team, as well as any barriers or future directions that they see. The second qualitative study we're looking at is going to interview patients who've come through our VA Connecticut ORC and have worked with our peer specialist, again, looking into their perceptions of what those interactions were like, any barriers, what was useful, and future directions there. So in addition to those qualitative studies, we have submitted a grant for a hybrid effectiveness implementation study to get some objective outcome data on the effectiveness of peer specialists in these pain management teams, as well as some insight to the optimal way to implement these nationwide. Now, I had hoped to have some of that pilot qualitative data to share with you all today, but as it so often happens, that data wasn't quite ready yet. But thankfully, we have our ORC peer specialist, Kevin Fisher, here with us today, who's graciously agreed to answer some of those qualitative interview questions. I've adapted them into a more streamlined version so that we can get some of his perspectives and insight into his both journey as a patient through the pain management system, as well as his perceptions into his role as a peer. So Kevin, thanks again for agreeing to answer some of these questions for us. Starting off real broadly, would you mind just describing what your experience as a patient was pursuing pain management?
No, not at all. And thanks, Dan. So about 11 years ago, I broke my back in the Navy, incurred a pretty nasty injury. I fractured all 5 lumbar vertebrae and ruptured a couple of discs. And so the need for pain management was there. And so I got myself hooked up with a doctor and got myself some pain meds. And I thought everything was going really well for the couple of years that I was on the pain meds. For the last few years I was in the Navy. And as it turns out, I was relying more and more and more on my pain medication to be able to do the job. So I followed pretty much the classic addiction path. To couple that with my PTSD, I had a really rough time. And so what really helped me out the most was going through some of the chronic behavioral therapies and some of the cognitive behavioral therapies that I went through with the ORC team before I became a member. And I found that the ability to reach out and to talk to other veterans and to just guide them along and to show them the resources that are available is probably one of the most valuable things that I could do for somebody, is that peer navigation, navigating the VA.
I appreciate the insight, and it sounds like as you were connected with some of the eventual treatments, you found a lot of success. If you wouldn't mind looking back, what were some of the barriers you experienced in your initial pain management journey?
I did. I found a lot of successes with the programs I went through with the ORC, but a lot of the barriers that I initially encountered were that I felt like I had nobody to talk to that understood what I was going through. I didn't have any sort of a common ground to talk to my doctors and say, hey, look, I'm experiencing chronic pain. I'm experiencing PTSD. I'm experiencing all of these things that are all this crushing weight that's coming down on me. What I really need is a lifeline, a way to get the services I need immediately without having to go through all the red tape. And that has been one of the most helpful things I've found so far, is to be able to reach out to my fellow peer specialists, now that I am one, learn a little bit more about how to navigate the services of the VA and how to offer them to veterans, and to get veterans connected as possible to the VA.
Okay, so it sounds like initially there was that sort of stigma around your own pain management care, sort of a lack of knowledge of what existed, and not really having someone to speak to navigate that. And so I was going to ask you what you would have liked to see available, and it sounds like you're describing a peer specialist would have been really helpful as you were navigating the system. So I appreciate that insight. I do want to ask you a little bit about your experience as a peer specialist and how you found engaging with patients in that capacity to be.
Well, certainly, I find it very challenging at sometimes to be able to reach out and to engage with a veteran that pretty much represents a mirror of myself from about 4 years ago. And that is a very challenging experience for me, is to basically look back into my own eyes 3 or 4 years ago and to think about what did I need at that particular point in time. And that is one of the most helpful strategies that I employ, is to look back at my own journey and say, gee, where was I at this point in time when I was exhibiting these behaviors? What could I have done for myself? And then try to reach out and offer that support to the veteran.
Wonderful. And so, for the last 6 to 8 months, you've been part of the pain team. What's your interaction as a peer specialist been on these interdisciplinary pain teams?
I find that I am really well integrated into the pain team because we get together, we have discussions about chronic pain, and then when we start to brief a new patient, one of the things that I really like to see is that everybody on the team has an equal voice. It doesn't matter what your actual position, your job is on the team. Everybody has a voice and is able to speak up and bring their own experience to the table, because there are quite a few things that sometimes we just miss. I miss things a lot myself. And so I like the opportunity to go back and to pick others' brains and to kind of get a little bit data back to see, am I being effective? And so far, I feel like I have been mostly effective. And most of that effectiveness has come from my experience with pain and my experience navigating the VA.
Yeah, well, absolutely. And having worked with Pierre and the team, I think it brings a valuable insight to the rest of the team during these interdisciplinary meetings. Let me ask you, in terms of your work with the team so far, are there any current barriers that you've come across in your work or at the facility?
There are a few small barriers, and a lot of the barriers that I come across have to do with the inability to believe that somebody can be in the amount of pain they're describing and yet still stand up and walk into the VA. It's a lot of it is disbelief. A lot of it is the social stigma surrounding chronic pain. And I think one of the biggest barriers that I found is the ability to come to a doctor myself and say, I think I have a problem with opioids. Can you help me? Because that comfort level just isn't necessarily there between patient and provider. It's a little bit scary. So that fear of admitting that something is wrong with me or that I can't handle something that's happening to me is one of the biggest barriers to my work.
Yeah. It sounds like a lot of that stigma that we've sort of talked about or touched on throughout today is one of those barriers. And it sounds like the peer is well positioned to serve a role kind of bridging that, addressing that, and helping get past it. Let me ask you, what sort of factors or what sort of training do you think, in addition to all the training peers get, what sort of factors or training help make a peer be most effective as part of a pain management team?
I think one of the best tools available would be like chronic or cognitive behavioral therapy for pain, and the ability to reach out and to draw from the veteran what's actually going on.
Absolutely. And you gave a great example of one of the non-pharmacological interventions. Do you think it's also been useful having experience navigating the breadth of non-pharmacological options?
Oh, by all means. When I first started working for the VA is when my eyes opened to the sheer volume of services available and the amount of support available that most veterans out there don't know about, don't care to know about, or just don't have the information. I think one of the absolute biggest things I can do is serve as a bridge between the things like the aqua therapy, the acupuncture, the non-pharmacological types of treatments that are available to us. And sometimes just sitting down and talking with somebody is what's going to get the job done.
Yeah. To Sarah's point, it's a lot more impactful coming from somebody who's been through it or had that lived experience than it oftentimes can be from the provider. All right, a couple more questions. Do you have any ideas for how best to integrate peers into pain teams that are looking to begin this offering this service as well?
My first feeling on that is yes, every pain team should in fact have a peer specialist. And it's my feeling that the best and easiest way to integrate a peer specialist into a pain team is to start off certified as a peer specialist first, get a little bit of experience in the community, sharing your story, and then learning how to tune sharing your story to specifically reach out to that chronic pain sufferer, to be able to show them not only is recovery possible, it's doable, it's a livable condition.
Absolutely. Well, thank you for that. And then my last question, how do you think your work as a peer specialist has helped with your own journey in this past year?
Personally, I feel that I have come miles in this past year that I've been working as a peer specialist. Like I said, my eyes have been open to the resources that are available to me. And one of my biggest, most impactful thoughts would be that I have seen a lot of veterans come through these clinics like ORC, like physical therapy clinics, and not have any trust whatsoever in the providers. That trust relationship is probably the single most important piece to build in order to forward the work that we're doing.
Absolutely. Well, Kevin, thank you so much for giving us some insight. As I mentioned, we hope to get a lot more information through these qualitative interviews and really compile it. Look forward to sharing that in the future. I believe with that, that is our presentation, and we're ready to open it up to any questions anyone might have. Thank you.
Hey, Dan and Ann and Sarah. It's Matt Chinman. How are you? Could you say more about is it the trial that you are talking about? Is that submitted, or is it you have it and it's about to start?
So there's 2 studies ongoing and 1 that was submitted. So we have 1 funded study, which is actually how we funded Kevin's work in our clinic, which is a multi-component tool, like a web-based tool for supporting opioid tapering. That's an ongoing HSR&D pilot, and peer support is really one of many things that is sort of in a package to help people taper. And that study is recruiting veterans out of Philadelphia. But we sort of developed it locally. And so that's how the peer ended up also being hired locally. And then Will Becker and Karen Seal have one of the pain management collaboratory funded trials. It's called Hope with a W, and it's a 3-arm randomized trial comparing basically CBT for chronic pain in a group embedded in primary care to a usual care to this whole health arm. And the whole health involves whole health coaching. And so although that, as I mentioned, that study didn't set out to really be about peer specialists or peer work, I think 3 of the 4 sites have certified peer specialists serving in the whole health coach role. So we're interested to see, like, especially qualitatively, what they learn from the peer specialists doing that work, as well as the patients working with that peer doing full health coaching. And then I submitted an IIR to study putting peers on pain teams, a hybrid trial, in December. So we have a while before we'll hear anything more.
Great. Sounds like a nice lineup.
I hope. Other questions?
Well, I'll have to get you to present again, or at the peer think tank, the VA.
Yes, when I have more data, I will definitely come back to present. Yeah.
I have a question and
Yes.
thoughts. I am a chronic pain patient myself. I have a rare disorder. So I've had multiple surgeries too in a very short period of time to hopefully fix my feet. And that didn't quite work out the way I wanted it to. But we're talking about a definite shift that's happening around opioid use. I mean, I can remember having foot surgery in 2003, and it was up in the office that I was going to for my pain stuff. Remember to take all your medicine. And they were talking about opioids. They weren't talking about anything else. So I'm really happy to see the shift that's happening. And we are working on the same thing here in Butte County in California. We just got the $200,000 grant to become a nonprofit here to help lead peers in this way. But that's my feeling. I want it in all walks of life in our medical field. I think it belongs there, peer support. You know? And not only that, but it'll make people not feel so scared when they walk into a doctor's office and get a chance to have somebody explain what they're going to do to you first before they do it. It makes a huge difference. So I would like to keep track of what you're doing. So maybe we can compare notes, because there's a heck of a stigma here. We have a large mental health challenge here, and we had the fires that it rolled through here, which didn't help either. So it's like layers of stuff that trying to get through the bureaucracy and the stuff that's going on. And I'm talking about a county. I'm not talking about the VA. My hat's off to you guys for figuring it out and using peers to do that.
We thank you so much, Sage. We have about 4 more minutes. And so just to remind everyone, first of all, to thank our presenters. Thank you so much. And thank you to all those who attended. If you could, if you haven't yet, if you could please leave your name and email in the chat so that we can send an evaluation out to everyone to get your collect your thoughts about this presentation and the Zoom conference. So we have time for maybe one more quick question.
Hi, this is John Aguirre. I'm in Central California. I do have a quick question. So a lot of our peers here use medical marijuana for pain, for pain management in concert with their medical pain management. How you guys are a federal program, so I know you guys can't really work with that. But does anyone else on the panel or in the audience, how do they incorporate those two items to make it manageable?
Yeah, you're right. As a federal organization, we don't have a lot that we can say or do on that. I don't know if anyone else does. I also see that Tiffany has up her hand.
Hi, I'm not a veteran, but I am a disabled woman that has a chronic pain condition. And, the thing is that I know that a good number of people who do utilize medical marijuana for pain. And I have a close friend who was actually able to get off of heavier pain medication in that way, and to avoid opiates. And so that can be a really important thing. And I just wanted to mention, that it's really great to get creative with some of these solutions because, for example, I have some medication allergies, and so I can't take gabapentin or Lyrica. And that can make it very difficult to treat pain when it comes to, not being able to treat the nerve pain in that way. But the solutions, chiropractic, acupuncture, things like different kinds of physical therapy can be really helpful. So I just wanted to mention that, and also that women are statistically not as likely to have their pain taken seriously. And that's been such a major problem. I found out about my endometriosis 2 years ago when I had level 10 pain that did not respond to any pain medication and ended up in the emergency. And it wasn't as if that was the first time I'd had that kind of pain. And so, just an urging to really be on the lookout for biases because they do exist, especially for women.
Thank you for sharing that.
Dr. Harvey, it's been wonderful.
Thank you so much, everyone. The recording of this and the slides will be available. So hopefully we have your emails and you will be receiving an evaluation. And thank you again, everyone. The room will stay open so people can come in for the next presentation. But thank you again to our wonderful presenters and to everyone who attended.
Thank you.
Thank you.
Come on.